Over to you, Mark.
Thank you very much, Amir. And we should be calling this session with adrenal gland, but actually review my cortisol levels in the last half hour, trying to get connected. So apologies. And Amir is kindly going to be just forwarding my slides. So apologies for the intermittent necks. So Amir asked me to talk about something relevant, and I wondered whether a sort of reflection, as I'm old and experienced now and far from the cutting edge, whether some reflections on current controversies in clinical thyroidology. I sent him a few topics as a suggestion, and he threatened to bring me back next year. So I'm going to call this part one, but it will be dependent on the feedback. And so I suspect I'll know very quickly whether this worked or not. So the first slide, up in terms of the controversies that we agreed we'd cover, we thought we'd talk a little bit about the controversy about LT4 and LT3 replacement and hypothyroidism, the role for ultrasound surveillance in small thyroid cancers, and also increasingly the patient preferred long-term option of low-dose antithyroid drug therapy for hypothyroidism that persists. And this and the theme actually going through the three areas of controversies will be the increasing role of patient preference in their management, as opposed to when I was growing up and the doctor just said this was what's going to happen. So next slide, please. Yes, patients, right? And this was brought to mind recently as there was a study showing that if you withdrew levothyroxine, up to a third of patients didn't actually require levothyroxine long term. And there's quite a wide spread of reasons, from thyroidectomy for cancer to much more subtle levels of thyroid dysfunction. And indeed, in the community now, in autoimmune hypothyroidism, nearly all patients commence on levothyroxine are at very borderline levels of serum TSH, usually with symptoms. Next slide. So the first case I've got is a woman who's age 35. She works in tech. She got Graves' disease with quite marked severity with orbitopathy. I've got access to excellent thyroid surgeons, so I often encourage particularly younger women to consider a total thyroidectomy. She had a good surgical outcome by all the surgical criteria, so was happily discharged by them with a good scar, euthyroid on thyroxine, and with no parathyroid disturbance, and all her voice intact. So that was deemed to be the excellent surgeon act, but as many of you will know as physicians, perhaps 2 or 3 years later, they turn up on their levothyroxine with what is apparent subtle or over replacement with levothyroxine, with a high normal free T4, a low normal free T3, a suppressed serum TSH, but still persisting symptoms that the patient is associating with thyroid hormone deficiency. Next slide, please. So traditionally, the model that we have is that we have a serum TSH as the most sensitive indicator. I'm always struck by how in congenital hypothyroidism, your pituitary knows within hours that you've been born without a thyroid, which is how, of course, the Guthrie test works on the heel prick of babies at 5 days old. And that we have this issue that the symptoms of hypothyroidism are very broad and non-specific. And the Colorado study in Denver many years ago suggested that up to 25% of us healthy population could be hypothyroid based on symptom scores alone. Next slide, please. I think it's therefore worth going back many years for the first descriptions of myxedema, and this was the very first 8 photos of a woman progressing through myxedema by William Ord in 1878, within 7 years, with a marked myxedematous appearance on the right. Next slide, please. And then when I started as a registrar in Newcastle in the early 90s, for the first time giving thyroid hormone replacement. In this case, it was an injection of a sheep thyroid extract, and the initial person, the woman who was treated for 28 years, and so 74 was a pretty good age, and she was estimated to have received the thyroid extract from the equivalent of 870 sheep. Next slide, please. And this is the picture of her presentation and her improvement clinically with the hypodermic injections, and she was receiving levothyroxine 2 or 3 times a week by injection. Next slide, please. So what happens now is that many patients are actually being given levothyroxine even with normal thyroid function tests. So one of the problems I have, and I think we all now need to do, is go back to the original diagnosis. Why were they put on thyroxine? What was the level of serum TSH? What's the patient expectation of improvement? Because often it's assumed to be the levothyroxine not working when actually it may have been an inappropriate diagnosis at the time. Next slide, please. So the original story, of course, going back to Murray, is that they were giving desiccated thyroid hormone containing T4 and T3, and this ratio is much lower in the animal thyroid glands than in the human glands, but this was the typical preparation for many years until levothyroxine was created. Next slide, please. And so the typical thyroid hormone production is that you're needing roughly 26 micrograms of T3 a day. The majority comes from a conversion of levothyroxine with a small amount direct from the thyroid gland itself. Next slide, please. So the problem, and this T3 hypothesis, is that you're not quite replacing like for like, in that you are requiring all your T3 to come from T4, and whether that's true physiology. Do you have T3 deficiency within the tissues? Can you rely on your pituitary gland to assume as your surrogate marker that you have satisfactory thyroid hormone replacement? Next slide, please. So there then was a whole series of trials, because liothyronine obviously was preferred, is the synthetic version combined with T4. Many trials not showing any difference in a randomized controlled trial of any benefit in subjective terms, in objective terms, but one or two studies saying subjective issues. Sorry, next slide, please. If you lost me.
No, we've got you. So the next slide is the graph.
Yeah, so one of the problems with liothyronine is that it is not a slow release preparation as in levothyroxine. So then you do have these peaks 2 or 3 times a day post administration. So again, not true physiology. Next slide, please. So the issue has always been, how do you recreate this normal physiology? And it is possible to do with conventional levothyroxine with low-dose liothyronine in addition. Can you therefore, but the trials really didn't suggest an overall improvement in the symptoms, when patients are blinded. Next slide, please. We are still left with the problem that many patients on levothyroxine, and there are various estimations, 5 to 10%, of patients who claim they are unhappy with their levothyroxine replacement. And there's been 2 largest population studies, one in Denmark and one in the US, I'll mention in a minute, showing the range of patients, the range of serum TSH, dominated by women, often in sort of the perimenopausal years, often with a relatively high education, quite a sort of a group that are quite specific who seem to have this lack of energy. Next slide, please. The Americans and the American Thyroid Association looks at this impaired quality of life. And again, very poor studies in the sense that this is self-reported dissatisfaction. And remember that in the States, it's the 3rd most commonly prescribed medication, and in the UK, it's the 4th most commonly prescribed medication. So a large number of patients, but this very significant minority. Next slide, please. So in conclusion, I think we really don't have the answer to this, and it's going to be difficult to ever prove it. There's really been no study that showed who would benefit from combination therapy. Whether you're looking at deiodinase abnormalities, genetic subtle abnormalities, whether you're looking at T4, T3 levels, you are left with a clinical trial of combination therapy for 2 to 3 months, and trying to see subjectively whether the patient improves. And I think that we are now left, particularly I think it's a reasonable thing to do in our case where there was a complete hypothyroidism from surgery. Moto's patient got complete deficiency I'm less convinced about, but I think we have to accept now that the patient population is so aware of this issue that in a sense you are almost obliged to offer them a benefit of the trial for 3 months to establish, and actually if they benefit, and actually that I think is reasonable to allow them to actually, for them to make a personal decision as to whether they benefit or not, rather than the doctor just saying, as current can be the practice, no, I don't agree with that as a principle. It's a simple thing to do, and in 3 months you get your answer. And some of these patients are attending their primary care physician on multiple occasions, and for whatever reason, if they feel happy at the end of their trial and benefit from therapy, then they can continue that long term, and I have no objection. And I don't, I suppose, at that point mind why they feel the benefit. Next slide, please. Just as a cautionary tale in terms of going back to George Murray, he was very good actually. He, a year or two after his groundbreaking study, he published 3 further patients which didn't have the great outcome that the first patient had, and in this series of 3, 2 died from cardiac failure. He made the point that actually replenishing thyroid hormone in the presence of a cardiomyopathy may actually lead to sudden death rather than improvement. So just a cautionary tale on the benefit of T3 and T4. Next slide, please. So the second sort of issue I was going to raise, this is a woman who was aged 49 years, a corporate lawyer. She was from Eastern Europe. She attended in 2017. She had a rather unusual presentation where a massage therapist noted a neck swelling, which actually turned out to be a rib. But that led to an ultrasound scan, which identified a 3-centimeter nodule, borderline characteristics on both ultrasound and cytology. She was advised surgery and the discussion was for the benefits of a right hemothyroidectomy or for consideration of ongoing ultrasound surveillance. And I'll explain by the end why this case brought home to me why this particular topic. Next slide, please. So when we're looking at thyroid incidentaloma, so this is very much an incidentaloma, there's a wide debate about what size you think should be worthy of a fine needle aspiration. Do you rely on your good radiologist? And I'm fortunate to have excellent radiology opinion, and I almost treat them as, you know, as gospel, what they come up. I think so. If it's a thyroid cancer, I've got complete faith in them. What do you do if you're having complete or non-diagnostic cytology, and how long do you go on for? And what also does this cytological diagnosis of malignancy mean biologically, when we know that 1 in 10 of us at post-mortem will have microcarcinomas, micropapillary carcinomas, which meant nothing to us in our lives biologically. Next slide, please. One of the issues has been the overdiagnosis, if you like, because of the increased amount of imaging, and increasingly we're seeing referrals from neck surgeons and people having CT and MRI scans of the chest or the neck and finding incidental swellings, prompting the ultrasound scan. But there does seem to be a true increase in both mortality and in terms of incidence of thyroid cancer, particularly in these small papillary cancers found as incidental findings. And there's some debate about whether actually obesity is correlating with the increased incidence of thyroid cancer in a US population. So there does seem to be a genuine increase in the incidence of thyroid cancer, in addition to perhaps the overdiagnosis from increased imaging and incidentalomas. Next slide, please. So what we've been fortunate to have is the Korean population who have about 10 times the incidence of thyroid cancer than anyone else, partly because they seem to be the most ultrasound scanned population in the world in terms of necks. I'm told that almost you got an ultrasound scan of the neck when you went to the supermarket if you wanted one. So what they've actually got is a big population of incidentalomas, and now they've started, rather than everyone having surgery, they've started to look at whether observation is a reasonable approach, partly because in follow-up studies the outcomes didn't seem to be any better, and then you had a surgical morbidity from what might be unnecessary surgery. Next slide, please. So I was very impressed with this Tuttle presentation. I read he actually took what they confirmed as micropapillary thyroid carcinomas in a large group. They're all less than 1.5 centimeters. And he established 6 different patterns within that group. And this therefore allows the concept of ultrasound scan surveillance and targeted surgery to those who are starting to behave badly, and rather than routinely offering everyone a surgery. The next slide, please. So he created this, what they call tumor genetic growth pattern. He created 6 characteristics according to early increase, late increase, whether it remains stable, whether they increased, whether they decreased. And I just think this is quite a nice sort of sense of how you can really sort of classify, individualize your care and start to monitor people rather than jump in and offer everyone surgery if the patient's psychology does allow that. And I think we have to remember that the regular screening by ultrasound scan and the waiting for the result does have a morbidity in itself. So you do need to have a good patient psychology if you're going to enter into this process. Next slide, please. So in terms of the conclusions, we've got the common papillary carcinomas in postmortems. We've got a relatively low rate of recurrence if you have surgery. In general, a 3 millimeter increase in the growth of the nodule will trigger the surgery. So we do have some clear guidance if you've got good ultrasound. The other interesting factor is that the younger you are, the more likely you are to progress. So clearly, if you've got somebody in their 20s and you're going to offer them 60 years of follow-up, that might sway your decision to offer early surgery. And we do know now that with increasing evidence, the ipsilateral lobectomy offers you a permanent cure. So you do have that ultimately as your outcome, as your surgical outcome, and you know that over 80% of patients will not need levothyroxine with a lobectomy. You also know that they don't need any traditional follow-up in terms of treatment, radioiodine, TSH suppression, or regular ultrasound scan. But increasingly, surveillance is offered as part of patient choice now through most thyroid MDTs. Next slide, please. So the cautionary tale on this case is that the patient actually proceeded to a right hemithyroidectomy, and actually the concerning nodule at 3 centimeters was confirmed to be benign, but actually next door to it was a 3 millimeter PTC. Everyone agreed at the MDT this was a curative procedure. I met her 5 years later, and this time she really presented with very non-specific symptoms. Her concern was that she had thyroid failure, and really she just wanted to check her thyroid function. To this day, I know no reason why I requested the thyroid ultrasound scan. It was completely non-indicated because neck exam was fine. And this showed 2 lymph nodes that were quite large in the right side of the proceeded to a left lobectomy that had no tumour. In the right left, there was histology confirmed in 4 out of the 28 nodes. So there's just a little reminder that this sort of theory that we can be completely reassured with these small PTCs is not a complete absolute. And I must say this was quite a cautionary tale in my practice. Next slide, please. So the third area I just want to consider, this is a 48-year-old lady, a businesswoman, as she presented in 2017 with a benign multinodular goiter, which had a dominant right-sided nodule, but actually it turned out to be 2 nodules, 2.1 and 2.5 centimeters, and it was all confirmed to be benign asymptomatic. But 5 years later, she presented because the nodule, the swelling was getting bigger, and in essence, she went for a successful radioiodine ablation, which shrunk both nodules and had an excellent outcome. Of note, thyroid function was normal throughout, but on the second occasion, she was TSI or TSH receptor antibody positive. I then met her again 2 years later, and now she's presented with quite significant Graves' disease, and the TSI that was mildly positive is now strongly positive. She's been commenced on carbimazole. Now, in my practice, patients are often going through to the NHS clinics, and so I've got one opportunity to give them a bit of a steer of where I think they're going in the future. Are they likely to enter remission or not? And when I talked to her, this week, I had this conversation, when I talked to this lady, it was quite clear that if she, and I was pessimistic in terms of which half of the draw she would be on, I thought she was likely not to enter into long-term remission because of the strength of the TSI. And I just went through the future treatment options, and she was a sensible lady and was quite clear she wanted to stay on long-term carbimazole if that was an option. Next slide, please. So the safety of long-term antithyroid drug treatment, again, as a patient-driven choice. and needs to be considered because it's often requested. And this is a nice, the reference there at the top, a nice review article looking at all the various studies available. So a large number of patients followed up for a reasonable number of years for really, I suppose, focusing on the side effects and the safety, and actually showing that once particularly you've got through that initial phase, the major and minor complications are relatively rare and less children are needing higher dose. So the sort of talking about process, they've got evidence of the Graves' disease returning, and therefore you know they're going to need 5 milligrams of carbimazole daily indefinitely. Is this a safe choice? And this is now considered as patients as a preferred option rather than definitive treatment with radio-IOD or with surgery. Next slide, please. And of course, one of the key things we have to be aware of is that the patient's perception of body weight, and it's particularly a concern with radio-IOD. And actually, there are reasonable data that actually with antithyroid drug therapy, your body weight is less. There's less gain in weight post-treatment than with radio-IOD, which is a major factor in patient satisfaction. Next slide, please. What then my cautionary tale on this case is that this is a study that's literally just been published this month. It's looked at the MESA, the sort of a group of cardiovascular outcomes associated with antithyroid drug therapy, radio-IOD, and surgery, and actually showing this large group of patients. This was in Taiwan, over 100,000 patients, newly diagnosed hypothyroidism, that actually surgery on radio-IOD offered you a lower risk of MACE compared to the antithyroid drugs. So it's just a cautionary tale that apparent safety in that anecdotal way may not be safe as a group. Next slide, please. So the 3 learning points we can discuss, and number 1 is consideration of a trial, particularly in the athyrotic patients, i.e. complete hypothyroidism. We've got to accept the potential psychological benefit in patients who at least trial and know they've tried something and they're not missing out on something that improves their quality of life. Secondly, we've got an era now where we're considering more and more active surveillance in papillary microcarcinomas in tumours less than 1.5 centimetres, again with patient choice and with good cytology, knowing that an increase in 3 millimetres means you can opt for surgery then, and you haven't changed their long-term outcome. And thirdly, it's a patient-preferred option that long-term, low-dose antithyroid drug therapy is increasingly being sought, rather than the more traditional definitive treatment with either radio-IOD or surgery. Next slide, please. So this is a mere, I'm sensing, making a decision on whether I'm back next year or not. Thank you very much, Amir.